Hello, this is Dr. Raymond Lamb from the University of British Columbia. It's my pleasure to welcome you to part 2 of our measurement-based care training series. In part 1, we introduced measurement-based care and how using it can improve outcomes in people treated for depression. In part 2, we'll go over some of the clinical scales and tools that we recommend for measurement-based care. And we'll finish in part 3 with some simple medication algorithms that you can use when using measurement-based care. These are my disclosures and the sources of my funding. Our objectives during this session is really to describe some of the factors that you need to consider when using scales for measurement-based care, and then to look at 2 symptom scales and 2 scales to assess functioning and side effects that we recommend for use in MBC for depression. These resources are also available on our website, workingwithdepression.psychiatry.ubc.ca. For our Embed project, we have designed an implementation plan that has features that address issues related to the hospital, for patients, and for doctors, which includes this MBC training program and also a package of scales that we recommend for use. And we'll go over that package of scales in just a few minutes. Rating scales in psychiatry are like laboratory tests for the rest of medicine. But rating scales have many different purposes. They can be used for screening for depression. They can be used to help with diagnosis, with selecting treatment, with adjusting medications and other treatments, and also to monitor for relapse prevention in people who are on maintenance treatment. So many uses for rating scales. When using rating scales, we have to understand that they have to be psychometrically sound. In other words, they have to demonstrate that they're reliable. Are the questions internally consistent? Do the scores, are they remain stable when we test and then retest people later? We need to make sure that they're valid and that they measure what they're supposed to measure. And in particular, if a digital or online version is used, does the scale still perform the same way as the paper pencil version? Importantly, if we're using it to monitor treatment, we have to make sure that the scales are sensitive to change, that change in scores actually reflect clinical worsening or clinical improvement. And it's important to know what's the minimal score that represents a clinically significant change. We have to also ensure that the rating scales are appropriate to the setting and the purpose. So for example, for research scales, the more items, the better, because it gives you a more reliable measure. But for busy clinical settings, we want the fewest number of items in order to reduce patient burden in completing the scales. So we have to remember the psychometric properties of the scales when we're using them. The good news, though, is that we have many validated scales that reflect very good psychometric properties. We also have to remember that scores cannot be considered just in isolation, that it has to be interpreted within the patient's context. So, for example, are there external life events that might be temporarily increasing scores? We need to consider whether there are language, cultural, and cognitive changes that might interfere with evaluating the score. Has the scale been appropriately translated and validated in the other language? Are there any cultural differences in terms of responding to a questionnaire? And in particular, are there cognitive or literacy issues that make it difficult for patients to understand the questionnaires? Finally, there are also individual differences in that we know some patients over-report their symptoms and some patients under-report them. And there may also be some sensitive questions, like questions about suicide, that either make it difficult for patients to answer, or conversely, sometimes it's easier for patients to answer questions like suicide on a questionnaire rather than telling their clinician. So the important thing is never treat a number. Just like we would never just treat a lab test result, we don't treat a score on a questionnaire. We have to consider it within the patient context. So as I mentioned, there are many examples of validated outcome scales that can measure symptoms, functioning, side effects, and quality of life. And this table reflects some of those validated measures. There are clinician-rated measures based on interview and talking with the patient. And then there are patient-rated measures in which the patients respond to questions, and so it's a self-rated scale, a subjective scale, as it were. Clearly, for busy outpatient settings, busy clinical settings, we recommend the use of patient-rated scales because it's much easier and takes less time than having the busy clinician ask all of the questions on a clinician-rated scale. And the good news is that all studies have shown that subjective scales, patient-rated scales, correlate very highly with clinician-rated scales. For the most part, both of them measure similar things, and either clinician or patient-rated scales can be used. These are the 4 scales that we chose to use in the MBED study. 2 scales that measure symptoms, the PHQ-9 for depression, the GAD-7 for anxiety, 1 scale to measure functional impairment, the Sheehan Disability Scale, or SDS, and 1 scale to measure side effects, the FIBSR. We chose these scales because they've been validated and widely used in depression studies. They're easily completed by patients, very short. All 4 scales can be completed within 5 minutes and often even shorter. Importantly, they're free to use and available in Chinese language and validated in Chinese populations. In fact, these scales are also available in many other languages that can be used elsewhere. So just to show you these scales, here is the Patient Health Questionnaire, or the PHQ-9. It's a simple 9-item scale that follows the DSM-5 criteria for a major depressive episode. And you can see that the patients just answer over the last 2 weeks, how often have you been bothered by any of the following problems? And they rate themselves in terms of how many days of the past 2 weeks that they have experienced these symptoms. It's a 0 to 3 scoring for each item. You add up the total score over the 9 items, and you come up with a score between 0 and 27. And you can see here in the table that depending on the score, you can get a criteria for how severe the depression, the person's depression is. And on this particular scale, a score of 10 or higher indicates significant depression, clinically relevant depression. So that's the PHQ-9. Here is the GAD-7, the Generalized Anxiety Disorder Scale, and it's a 7-item scale very similar to the PHQ-9, measuring 7 symptoms of anxiety. Again, patients rate how many days of the week that they have their anxiety. And the score on this scale ranges, the total score ranges from 0 to 21. The higher the score, the more anxious the patient is. And again, on this scale, a score of 10 or higher indicates significant anxiety. This is the functional impairment scale, the Sheehan disability scale, again, widely used in depression studies. It really has only 3 items, and it assesses impairment in 3 domains: the work-school domain, the social life domain, and the family or home responsibilities domain. Again, the patient just indicates how much interference and disruption they have in their activities within each of these 3 domains. The higher the score, the greater is the functional impairment. You add up the scores and you get a score between 0 and 30, where 0 indicates no impairment and 30 indicates extreme impairment in functioning. In this particular scale, a change of 3 or more in the score indicates a clinically important improvement or worsening in functional activities. And finally, this is the FIBSR, the Frequency, Intensity, and Burden of Side Effect Rating scale. And this scale was widely used in the United States STAR-D study, the large effectiveness trial in the United States. Again, a very simple scale, only 3 items. The first item asks how much of the time they experienced side effects in the past week. That's the frequency. The second item, in the past week, how severe were the side effects? That measures the intensity of the side effects. And then finally, the third item is how much have the side effects interfered with your day-to-day activities? That's the burden of side effects rating. And they simply fill in the item according to how much of the time that they're experiencing those particular issues with their side effects. For this particular scale, when we use it clinically, we actually look in particular at the third item on the scale, the interference with functioning, because that's the important aspect in terms of side effects. How much does it interfere with their functioning? And on this scale, depending on the score, may help you in terms of your clinical decision with that particular medication. So if they score 0 or 2, no interference, minimal or mild interference with functioning because of side effects, then usually no changes are needed in that medication. But if they score 3 or 4, if they have moderate or marked interference with their activities, then you really need to consider addressing that side effect. You may need to reduce the dose. You may need to give an antidote. You may need to look at other aspects for that particular side effect. And if they score 5 or 6, if they have severe interference with their activities or they're unable to function because of these side effects, then generally you need to change that medication. You may be able to get away with reducing the dose, but often a change is necessary because those are very burdensome side effects. So that's how we would use the FIBSR clinically, by looking at item 3. Now, this is a simple monitoring form that we recommend to be able to keep track of the scores over time in your patients. And so it's very easy to use. You give the date here, and on any particular date, you simply enter in the scores on the 4 scales according to the category of the score. And by using this, you can track improvement over time. Hopefully you'll see patients improve going from the red, higher categories down towards the green, which is really the remission areas or no impairment, no side effects areas for these particular scales. And we'll illustrate how this is used in the next few minutes. So let's go over some patient scenarios and illustrate how we used these measurements to support clinical decision making in treating patients with depression. So when David returns to follow-up at 8 weeks, he's been taking his escitalopram and he says, "Thank you, doctor, I'm feeling much better." And so because of that, if you were using usual care, you would keep him at the 10 milligram dose. But if you're using measurement-based care, your decision may be different. Now, if you're using measurement-based care, David would complete the scales before your appointment, and then you discuss the scores with him. And you show him that a score of 18 indicates that he's severely depressed, and a score of 12 indicates that he is moderately anxious, with a score of 26 on the SDS indicating that he has marked impairment in functioning. You still diagnose major depression, and you decide with him that he starts on escitalopram at 10 milligrams per day, but you also tell him that by doing these scales regularly, they can help to monitor his response to treatment. David returns after 3 weeks, and he's been taking his escitalopram, but he tells you, "I'm still not feeling good, doctor. My mood has not improved at all." And so if you were using usual care, you might increase the escitalopram to 20 milligrams per day. But if you're using measurement-based care, you might do things differently. David completes the scales before his appointment at 3 weeks, and he finds that when you discuss the scores with him, there's been actually some early improvement in his depression symptoms, and his scores decreased from 18 to 13. Similarly, his anxiety is a little bit better, with scores now down to 8. Not much change in terms of his functioning, and on the side effect rating scale, he only has mild interference from side effects. So because he's showing some of this initial improvement, you decide with him that he should stay on the escitalopram 10 milligrams in order to see whether he has continued improvement, since this is the start of getting better. And so this changes your clinical decision making because it's clearer that he's actually shown some early improvement from his medication. Now, in an alternate scenario, when he comes back, you see that, again, he has improvement in his depression and anxiety scores, but this time he has significant interference from his side effects. He scores 6, which is severe impairment. In particular, he notices that he has a lot of agitation and sleep problems with insomnia. So because he has this degree of problem with escitalopram, you decide with him that he will switch to another antidepressant, mirtazapine, which is a little bit better for sleep. So again, this is how having a side effect rating scale can actually help guide your treatment decisions to switch to a different antidepressant. Now, what if instead David returns for follow-up at 8 weeks, and he has been taking escitalopram 10 milligrams, and he says, "Thank you, doctor, I'm feeling much better." And so, because you decide to keep him at escitalopram, you decide to keep him at 10 milligrams. Using measurement-based care, David completes the scales, and now you notice he's had clear response in improvement in depression, anxiety, and functioning over the past few weeks. However, you note that he's not yet in remission of symptoms. He still has residual symptoms, particularly problems with energy and concentration, that is still interfering with his return to full functioning. You also note that he doesn't have much in the way of side effects, only mild interference with the escitalopram. And so because of that, you both decide together to increase the dose of escitalopram in order to deal with the residual symptoms and try to improve his functional impairment. In this alternate scenario, David has the same clear response in symptoms and functioning, still has the residual symptoms, but this time he has more interference with his functioning because of side effects. And because he has more side effects, you decide that he's not able to increase his dose of escitalopram, and instead you decide to add aripiprazole to augment the effect of the escitalopram with a low dose. Here's another alternate scenario when David returns for follow-ups. This time, he says, I'm feeling better, but I'm having some pretty bad side effects to the medication. And so because of that, you decide to switch him to a different antidepressant, to mirtazapine. But using measurement-based care, you have access to the FIBSR side effect rating scale, and you see by looking at the scale that, yes, he does have marked intensity of side effects, but they only occur about 25% of the time during the day, and they only have moderate impairment in his functioning. And so because of that, you decide with him that it's worthwhile to try switching the timing of dosing to take the escitalopram at night so that any side effects that he experiences may be while he's asleep and won't interfere so much with his functioning during the day. Now David returns for follow-up at 12 weeks. He's been taking 20 milligrams of escitalopram, and he says, I'm feeling well and almost back to my normal self. And so, again, usual care without scales, you might maintain the medication. However, if you were doing measurement-based care, you would see, based on his scores, that yes, his symptoms now are in the normal or remission range. He has no side effects to his medications, but his functioning has not yet returned to normal. He still has residual impairment in work functioning. And because of this, he's not yet in full functional recovery. And so you decide to add cognitive behavior therapy to improve his overall functioning and in particular his work functioning. This shows the monitoring form for David to show how, across a series of visits, by entering the scores according to the category of the scores, you can track his improvement over time and have an easy graphical representation of how he's doing. And importantly, you can see at a glance if he does not get better, if his scores remain high over time, rather than improving as it is in his case. And so that's how it's easy to track the scores on these 4 symptom measures using this simple monitoring form. So, just to summarize, these brief case examples really illustrate how measurement-based care can help with treatment decisions. That symptom remission is an important goal for acute treatment, but functional recovery is also important, perhaps even more important to our patients. And we really should be targeting functional recovery as the endpoint of treatment. Also, scale scores need to be used like laboratory tests. They have to be interpreted according to what else is other clinical information that you have when making treatment decisions. But certainly monitoring of scale scores over time can help, particularly with continuity of care in busy clinics, where the patients may be seeing different doctors from one visit to another. And this is a quick way to see how people are doing over time without having to go over all of the detailed progress notes. Thank you very much.